The first speaker is speech pathologist Jackie Gartner Schmidt, and she is my old friend. We met with each other in 2003, and since that we have kept our friendship until now. And I'm very glad to see Jackie today. And I'm sorry to make you busy when you are on your Saturday evening. Yes, but it is our great honor to have Jackie to share his experience. Let me briefly introduce Jackie. Jackie, he graduated from the Communication Science and Disorder University of Maryland, and he became the clinical fellow of speech language pathology in Vanderbilt University, Nashville. It's a very well-renowned institute. And right now, he has the associate professor of Harvard University since the year 2022, and also the professor of University of Pittsburgh School of Medicine since 2016. And she was been the co-director of UPMC Voice Center from 2003 to 2022. And she has many achievements in speech language pathology. And today she is going to introduce the conversation training therapy for us. So let's give Jackie a warm welcome and big applause to welcome his talk. Thank you, Jackie.
Thank you. Hi, my name is Jackie Gartner Schmidt. Thank you for this opportunity to speak to you today about conversation training therapy. Let's talk it through. In fact, in 2019, there was an article that was called just this, and I recommend you getting it as a complement to this presentation. If you can't, just email me and I'll send it to you. So CTT is based in perceptual motor learning theory, as many of our beloved voice therapies are, such as Laysack-Madsen resonant voice therapy or flow phonation, for example. The big thing with CTT is it's all about processing these sensations of voice and speech while the patient is talking. And I want to emphasize that even a little bit more, that truly the only difference between CTT and other voice therapy programs is that instead of starting on a simpler task, such as holding out an M, an N, an S, a V, an F, holding out a phoneme, and then hierarchically going to a word, and then a phrase, and then generalizing to conversational speech, CTT kind of flips that on its head, if you will, and goes directly to the stimulus being conversational speech right in the first session. So CTT starts off with high task complexity, i.e. conversation, and expects low task accuracy at the beginning of therapy. We'll talk about that in a little bit. So think of the next 15 minutes as a windshield tour of CTT. My hope being that it inspires you to learn more and read more. When I present on CTT, I usually use the example or analogy of a puzzle, because CTT is not hierarchically based. And with a puzzle, you can kind of start with any piece, except we are going to ask you to start with one piece. And that first piece is something called clear speech. Some of you may definitely have heard of it because there's loads of research on it now. When I first learned about it, I was doing my doctoral studies back in 1999. And when I was doing my dissertation, I had an audiologist who was on my committee. And she said, Jackie, you might want to read some seminal research by Pishney et al. In 1985 on something called clear speech. So of course I did. And so it was in the audiology, the hearing literature. And the first study, there was 3. The first study was patients who were hard of hearing were asked to listen to speakers speak normally and then speak with clear speech. Crisp, clear consonants, spitting out the consonants. And their first article showed that hard of hearing people found clear speech more intelligible, which is great. The second article that they did is that they did acoustics on the clear speech. And they found that by just giving the directive to speak clearly, some amazing things happen, especially for us as voice specialized speech language pathologists. Just by asking a patient to speak clearly, the intensity goes up, the inflection and intonation goes up, the pauses, there's more pauses. Later on, we found that mean phonatory airflow is higher. There's a decrease in glottal fry, and the speaking rate also decreases. These are amazing things, again, just from one directive. So when we ask patients to speak in our first session, we ask them to let's just have a conversation of your choice, and I want you to speak clearly. Pretend that I'm hard of hearing. And we as speech pathologists are like ear hawks. We're listening for crisp, clear consonants. We're listening for no vocal fry or raspiness. We're listening for increased pitch inflection while the patient is talking to us and we're conversing. And I often say to patients, I'm listening to what you're saying to me, but I'm also really listening to how you're saying it. And to that end, giving feedback when you're in conversation is as simple as being almost like a parrot, parroting back when you hear the patient do a crisp, clear consonant. So consonants in clear speech are really flow phonation and resonance, and that's what it is. But if a patient at the very beginning, when you ask them to speak clearly, they're unable to do it and you're perceptually not hearing it, what you can do is you can briefly decrease the complexity of the task and ask them to hold out some flow phonation and some resonant voice sounds and immediately get back into clear speech. And this is how I do it. I'll draw a figurine, and it's the nose and it's a side of them with the upper lip, the lower lip, the chin, the hard palate, the soft palate, the tongue tip, we know all this, epiglottis, the vocal folds, but our patients don't, and then the food tube, the lower teeth, and then the upper teeth. And so we use this, and then I give them 4 different colored magic markers. And this is a nicer representation. But I say to them, you've come to me because you want to sound better. And although I'm going to help you with that, first I want you to feel the sounds of speech and really highlight these vibrotactile anterior energy. So I might ask a patient to hold out an S, just hold out an S, and then to show on this figurine where they feel the energies, if you will, of an S. And if a patient writes the S in the back of the throat, just holding out a S, you and I know that that's not where we want them to be feeling it. So we can shift to a little flow phonation. Get a piece of Kleenex out and have the patient do a after they do a ask them to add an S. And usually that is all that is needed to now have them do an S again and say, where do you feel it? And all of a sudden they start feeling it here. And we can do this for different phonemes. Again, M, N, S, and F. If they feel it there, do this simple flow into resonant technique to get them feeling at the teeth, the lips, the tip of the tongue. Then we take that feeling and jump right in to conversation. Because consonants truly are just airflow and resonance disguised as letters. So one of the other things, this is a component part, again, you don't have to do this in order, is embedded basic training gestures. And this is something that Kitty Bertolini talks about in the Laysack-Madsen resonant voice therapy and confidential flow voice therapy. We ask patients when they're speaking and when we are conversing to randomly stain some consonants when they're speaking, so they get a feel of this tickle, tickle, tickle when they're talking, because the milliseconds that we land on a consonant when we're speaking is very different from when we're holding it out. So we want to prime the patient by sustaining some of these sounds. This is kind of weird. So I always say to a patient, don't worry, I'm not going to let you out of the therapy room sounding like this, but it's a task to get them aware of feeling the vibrations here when they're speaking. All the while, we are always checking in with their auditory sensation and their kinesthetic. So clinicians in CTT don't really provide a whole lot of feedback. Rather, we guide the patient to their own self-discovery by constantly asking them questions when we're talking, obviously about what they're saying, because we're having a conversation, but we're guiding their own self-discovery by asking questions. Did you feel a difference there when you were talking? Did you hear a difference there with different speaking and voicing styles? Because this goes right into negative practice, which is huge in motor learning theory, and I think one of the most important parts of any voice therapy program. Negative practice is having the patient speak in good voice and then speak in their not so good voice. They're inefficient versus they're efficient. Some people also will call this discriminatory practice. So when we're talking with the patient in clear speech at the very beginning, right in the middle of when they're talking, we'll put our hand up and say, okay, stop. Now I want you to talk in the type of voice that you came into this clinic complaining about, that you were rough or maybe raspy, that you felt a lump in your throat, or you felt tight or tired speaking. I want you to change your voice and keep talking to me how you're talking and conversing, but I want you to change your voice. And we do that right in the middle of the conversation, because it's important that this ability to recognize through sound and feel a change in the voice is important in every daily conversation, because life affects our voice. Life can hijack our voice, whether we're stressed or we're anxious or we're fatigued or like a headless chicken trying to do everything. And this ability to be able to change on a dime with the discriminatory practice is important. I give a analogy for a long time of we're training patients to really ride this vocal bike and balance their airflow, their phonatory mode, their resonance, and their articulation. But the real magic in learning how to ride a bike is not really being upright on a bike. If you think back to when you first learned to ride a bike, the real magic in learning to ride a bike is when you fall off the bike. When you fall off the bike and get back up on the vocal bike. So falling off the bike, if you're stressed, if you're anxious, you're fatigued, or if you all of a sudden are talking to someone who makes you nervous and you notice a change in your voice, can you get back up on that vocal bike? And the more I think about CTT and do CTT, I think that this is one of the most important parts of it. So much so that sometimes conversation training therapy, an alternative name could have been sensory discrimination in speech. So SDS, but don't worry, we're still going to call it CTT. All right, prosody and projection, prosody, inflection. I'm going to show you an x-axis and a y-axis, and I'm going to do a pitch tracing of my voice here. So along the y-axis, we have pitch, and along the x-axis, we have time. So I'm going to speak to you now, and in the United States anyways, it is normal for us to go down in pitch at the end of our phrases. But if we're not cognizant of it, this is what can happen. So here's my pitch tracing. Hi, my name is Jackie Gartner Schmidt. I'm doing this webinar for your voice conference, and I look forward to speaking to you all on the weekend. And all of a sudden, if I'm not careful, I've changed my voice and speaking pattern, but my voice especially, and I'm in the pitch ditch. So when we work with patients with CTT, we tell them that every time they say a new sentence is a chance to recalibrate and help your voice. Example. Hi, my name is Jackie Gartner Schmidt. I'm doing a pre-record and speaking for your voice conference, and I look forward to meeting you and talking in our Q&A this weekend. So every time I said a new sentence, I pitched my voice up so I had somewhere to go in normal inflection. But this pitch ditch is not just going down in pitch, it's also going down in airflow. So by pitching the voice up at each new phrase, but also having that clear speech. And remember, consonants are airflow and resonance, so it's two things. It can be very helpful to good speaking technique. One of the other concepts or tenets of CTT is projection. Sometimes we have to use a loud voice. We know that we can get louder either by squeezing and getting louder like this, which is not the right way, or we get louder by using airflow, and that's the healthy way. So again, when we think back to that concept of feeling the consonants, feeling the sounds of speech at the front of the mouth, when we get loud, we want to feel those consonants even more at the front of our mouth. Negative practice in all component parts of CTT, again, is gold. And I just want to also say that there's a lot going on in conversation training therapy. Not only are we having a conversation and thinking with the patient and the patient with us, they are thinking, they're talking, and they're also becoming aware of the sound and feel of their voice. So CTT may not be for every patient. In fact, I would not use CTT for someone who had functional aphonia. But Dr. Wang had said, and the whole world is getting older. CTT with presbyphonia can also work very, very well. If patients who are elderly have memory issues, CTT would not be good fit. But if an elderly patient has no memory issues, CTT can work really well. Practicing. Basically, practicing is just finding opportunities to really lock into this sensory discrimination when you are having a conversation. So pretty much any time we open our mouth to speak is a good time to practice. So the key takeaways for CTT are clear speech. Consonants are airflows disguised as letters. Vibrotactile sensation. Discrimination skills. It's really all about sensory discrimination in speech. Feel a difference, hear a difference. Feel a difference, hear a difference. And the third is you can practice in your daily conversation. You don't have to carve out time to practice. I do want to tell you we will be having a CTT webinar with my co-developer, Dr. Amanda Gillespie. Please email me if you want to be on the list. It will be probably late spring, early summer of 2025, and it will be a asynchronous video webinar and a synchronous virtual webinar. So it'll be both. So the time frame shouldn't be a problem. All right. Thank you so much for asking me to speak at this Taiwan Voice Society annual meeting, and a special shout out to Dr. Wang. Dr. Wang and I met in 2003 and have kept in touch all these years. Thank you so much for this opportunity. And please, I look forward to speaking to everyone this weekend in our live question and answer. Thank you. Bye-bye.
Thank you to Jackie for your very nice talk to start our symposium today. I would like to ask, is there any question or comment from the floor? Yes, I mean, Professor Amanda, who?
Can you hear me? Yes.
Hi, Amanda.
Hi, Jackie. Nice to see you.
Nice to see you too.
Yes, thank you for that wonderful talk. I had a question. Most of the people here are Mandarin speakers, a tonal language. So you talked about consonants. How would you apply that to people who don't speak English?
So people who don't speak English, but there's also, I mean, depending on any different language, there's only voiced and voiceless consonants, correct?
Yes, yes.
Right? So be it Mandarin, be it English, be it anything, the tonal is resonance, but the frication and the turbulent air in whether it's voiced or voiceless can be similar. So I'm not sure. Am I understanding your question? Can you give me? I'm not sure the concept and the physiology would be different.
I only bring this up because in Vancouver, I also have many Mandarin speakers, non-English speakers. And I know that my speech language pathologist sometimes struggles with that language barrier. Just wondering, for example, with your technique, how do you apply it to a non-English speaking patient population?
Yes. So again, I don't speak any other language. But what I would do is take the sounds of their language, again, voiced and voiceless sounds is all we have. And I would do the same sort of thing, that they would have to feel the anterior vibration, the teeth, the lips, the tip of the tongue somewhere with their different sounds in their language, but the concept of airflow and vibration and feeling it here is exactly the same. So they could be, and I've had people of different languages that don't speak English, they could be speaking to me and I can still be hearing and listening for this crisp, clear consonants, essentially.
Thank you, Jackie. Yeah, I have a quick question for you. Yeah, before
Sure.
we end your talk. And
Yes.
if I don't misunderstand you, these the techniques about the sensation and the memory, right? Yeah. So the old people without good memory, you will not use this technique. And we have many head neck oncology patients. Probably they have received radiation therapy. For example, probably they have sensation deficit on their lip or on their oral cavity. Yeah, do you suggest this kind of therapy for them because they have lost some sensation? Or you are going to test their lip sensation ability before you proceed to your training? Thank you.
Yeah, no, it's a great question. It's a great question. I think with patients that have decreased sensory sensation, be it they're elderly, be it from radiation, etc., that spending some time on the vibrotactile feel in phonemes. So spending more time maybe with a resonant voice, a Laysack-Madsen, so you build a hierarchy of different sounds and feeling it, and then you go to words, and then you go to phrases, and then you go to conversation, could be better, perhaps, although I still would try to build that hierarchy in one session and then go as fast as possible to conversation in that first session. Because whether a patient has some sensory deficits or not, we know through motor learning theory that making things a little more difficult at the beginning is still a better way to retain for retention and learning than having really good performance in a session. So I would do a combination, if you will, of hierarchical, but then jump right into conversation to see if they can hold on to that sensation that you just primed them with phonemes, like holding them out. If so, a hybrid, if you will. But it's a great question. But at the end of the day, they still have to figure it out, because we don't, the ultimate goal is conversation, is connected speech. So
yeah, thank you for your comment. I understand. So we need to combine every method to help the patient, because the patient doesn't have probably not only one problem. Thank you. Because of the time limitation, I have to say goodbye to you. But my heartfelt appreciation to you, and I hope I can see you in person soon in the future.
Oh, yes, very much. Thank you, everyone.
Yeah.
Bye-bye.
Thank you. Wish you a good weekend. Bye-bye.
Yes, you too. Bye.